Let's go through this team then. Who's making these decisions? And by the way, if I may, where I work, almost all the hospital administrators are MDs. And there's a lot of senior pharmacy in this group as well, some RNs as well, RNs and with doctorates. I mean, people who have really spent a lot of time looking at data. This is not non-medical people doing this work, which really does help, I would think.
Yes, and I think that this is what part of the transformation of healthcare management, where it's not just the clinical side being arbitrarily handled by physicians and the administrative side by administrators, is rather a collaborative process where you have dyads and triads, and we have IT. Let's not forget that IT is playing a major role in this process as well through EHRs and creation of protocols. So and I think this is where we have an opportunity, not just a collaboration, but also distributing the roles appropriately. People talk about atrial fibrillation managed by cardiologists. Should atrial fibrillation be just managed by cardiologists? I would argue no. It's such a prevalent condition that you have trained pharmacists, you have trained primary care physicians. They should be able to handle and then leave the part that is more complex, the associated heart failure, the associated hemodynamic instability. That should be part of the cardiologist management, but everybody should participate in the creation of those protocols.
You know, it seems to me that if everybody with AFib needed a cardiologist, we'd run out of cardiologists.
Yeah, and it'll be a problem with access for cardiologists. I think it's important, and I cannot emphasize more about, the protocols, even for discharge, because there's transition of care to reduce 30-day admission. I think communication, even though we all know that the hospitalist should be talking to the primary care physician, we think it's happening, but if you really look at it, it's not happening as much as it should.
Well, it has to happen, right?
It has
you can't
to,
just launch somebody out into the real world saying, we gave you these drugs in the ED, please call your doc and let them know.
And maybe they have the same kind of drugs at home or something else, and they go home and they start taking what they were taking at home. So again, the role of pharmacists in medication reconciliation and that transition. Now we have transition coaches for the transition
coaches.
Yes.
Now, I'm not sure that sounds okay to me.
They're very, very knowledgeable in trying to discuss, because the hospitalists and the primary care physicians don't always talk to each other like they should. So then we have these coaches who can talk to these people at their own time.
I got this view of, yo.
Take a knee.
What are you guys doing? I'm syntax is all. Somebody who can help coordinate. How about a coordinator?
Or navigator.
Yeah. Navigator, there you go.
Navigators.
But let's take a couple of these scenarios, and you alluded to the ED. Somebody who's on one of these drugs has a traumatic injury, car accident, whatever, and winds up in the ED. Who handles this in the emergency room? It isn't always somebody who's an expert in these drugs. How do you coordinate this? Or is everybody now an expert?
Quite a lot of facilities have an ED pharmacist working there, even 24/7, some advanced centers. So that's a good spot to be at when you have somebody roll in after an MVA.
Okay, so frankly, it seems to me the ED would be the spot to focus on all of this, because this is where people come in acutely bleeding, whether from spontaneous intracranial bleed or from trauma, and you get a medication list and you reconcile this, if you will, but you realize, oh my gosh, they're on one of these novel agents, pharmacy, and then pharmacy comes in. Yes?
Yeah, absolutely. So the emergency department is ground zero for all this kind of stuff. That's where a lot of the med rec has to occur, and that's where a lot of unexpected problems become discovered.
Like what? What are the unexpected problems?
So finding out that somebody who showed up in severe acute kidney injury was actually been taking, perhaps rivaroxaban at home, and they just took it right before they came in. So maybe they not be bleeding now, but we can expect to see maybe some fireworks happen shortly. And we really rely on our emergency department pharmacists to help triage those kind of issues. If we expect to use perhaps a rapid antidote and we want that turnaround to be quick, it's expected that our ED pharmacist makes that call to the IV room and gets the ball rolling, similar to our turnaround with Alteplase for stroke, for instance.
So are pharmacists on call in these emergency departments, or should they be 24/7, 365?
Absolutely. Again, pharmacy should be an integral part of any care team. Again, I cannot emphasize the word team approach enough. because they are an integral part of every team. And the ED plays a major role. Sorting out, you mentioned all those medications. Polypharmacy is a major problem. We all know that. Those patients show up with on apixaban plus aspirin plus ibuprofen and so on, and nobody has checked the list of those medications. So someone needs to pay attention. I think they'll do a great job.
This brings to mind something. I keep coming back to aspirin because it annoys me in AFib. But any of the NSAIDs with their effect on renal function, right? That's an issue. Why would you give, unless it's for cardio protection and ischemic heart disease protection, why would you give an NSAID to somebody and risk deteriorating renal function when they're on a drug that is renally excreted and an overdose of this drug is of concern? I mean, would you just wipe some of this stuff out? A lot of these NSAIDs?
Yeah, I would definitely talk to the patient about, listen, if you're reaching for this NSAID whenever you have a headache, like ibuprofen, for instance, stop. Please use Tylenol first instead. You're on an anticoagulant now, so anything that can affect your hemostasis, your blood, making you more thin, could potentially be the next thing that triggers a bleed.
All right, and let me ask this, because it just came up, it wasn't in our plan. If you're gonna reach for the Tylenol and you're on Coumadin, what's that interaction like?
Yeah, so I mean, that's an unexpected interaction too. I think a lot of people don't necessarily give that the credit that it does, but it can interact and of course increase the INR.
Sure.
So, and people just think it's common, safe, over-the-counter Tylenol, and maybe a lot of the education for around warfarin is focused on those leafy greens and the antibiotics, but they don't necessarily talk about the over-the-counter stuff. St. John's wort is one of the key characteristic ones that never.
Tell me
on
about.
anybody's
I don't
list.
know about this. Tell me about St. John's wort.
Oh man, and saw palmetto, all of these things. So St. John's wort is.
Those of us of a certain age are interested in saw palmetto. So tell me about this.
Oh man, so I mean, these are common over-the-counter supplements marketed to treat, mood disorders, or then palmetto for prostate. They are not benign, and unfortunately, because they're supplements over the counter, they're billed as safe. I can take them whenever I want. But the fact of the matter is, they interact with a host of medications, particularly with warfarin.
You know, I've seen a lot of these supplements advertised as it's all natural, therefore it's all safe. I can think a lot of natural things I wouldn't ingest.
An earthquake is natural.
An earthquake is natural too.